legacy effect of this study. Any of you sorority or fraternity legacy?
Oh, yeah.
So your mom, your dad, your mom
Well,
was,
my sister was my legacy.
your sister was your legacy. Anybody else? A mom? Mariah?
No, I had 5 sisters.
You have 5 sisters, so one of your sisters, so you're the
I had
legacy?
5 sisters. Yeah, I'm a legacy.
Okay. Anybody have a mom or dad that was in a fraternity, sorority? So tell them what that means. Tell them what, Mariah, tell them what a legacy is.
So I had 5 sisters that went to a university, and all of them were in the same sorority. So that meant I was a legacy, and it's pretty much if you have a greater chance of getting into that sorority because you have to pick them and they have to pick you. So if you're a legacy, you have a higher percentage of them picking you if you want to go there.
So because of work that was done, you benefit.
Yeah.
Okay. So in the DCCT, they have followed these people on out. So the study ended in '93. They continue to follow people who were in either of any of those groups to this day. So and what they have found is there is a legacy effect. If you were in these groups, then what happened over time is they moved towards one another. So the people in the intensive therapy probably lightened up a bit, so their A1Cs rose a little bit because the way we were treating people improved or changed. These people's A1Cs got better, so they kind of converged to the same points. But the people who were in the intensive group have a lower rate of developing complications than the traditional group. And so what they call it is a legacy effect. So you benefit, you continue to have benefits in the future because you had a period of good control. So that's another thing I use with my patients, is like any period of good control is going to pay off for you down the road. And so whenever they hit bumps and they lose control, it's like, okay, we just need to get back on track, but the good is still going to benefit you. So that's what they call that a legacy effect. Okay. All right, metformin. How many of you that have been at Good Shepherd and had a diabetic and they've been on metformin? Lots of them. Anybody have a diabetic who wasn't on metformin? Not really. Okay. So because of the evidence and also because the fact that it's fairly well tolerated, doesn't have that many contraindications, it's weight neutral, and it's cheap, we start most people on it. So unless there is a reason not to start somebody on metformin, that's your go-to drug for a type 2. Okay. So what are the contraindications? Well, there's a few. One is renal function. So this drug is eliminated by the kidneys, and if it isn't, it tends to cause problems, and it can cause a severe problem called lactic acidosis. This drug had a cousin that came out in, I don't know, 70 something. And by 1978, it was taken off the market because of increased deaths due to lactic acidosis. So when metformin came around, they would not allow that drug in this country for years. It was in Europe for probably 10 years before it ever got into this country because of the safety issues with the older drug. So now this drug has been on the market probably, I think it was 95. So it's been around 20 plus years. So renal function, they continue to modify this and loosen it. So I want you to know this. So those are those chronic kidney disease categories that we learned in renal. 1, 2, 3, 4, and 5. So if people's creatinine clearance is above 60, we don't worry that much about it. And we use the total max dose. If they're between 45 and 60, stage 3, you will see a lot of these people, older folks with type 2 diabetes or type 1. Avoid if kidney function is or expected to become unstable. So if they're stable in that range, you can use the drug. I rarely go above 2,000 anyway, because you don't get that much more effect above 2,000. So the maximum dose there is 2,000. So know that the maximum dose is based on the kidney function. 30 to 45, you'll see a lot of people in that range as well. Here they recommend don't start it, but if they're on it and they're doing okay, leave them on it. Just monitor it and don't dose them above 1,000 milligrams per day. Below 30 mils per minute, don't use. Okay. All right, the other would be unstable congestive heart failure. So most of the contraindications come because they put the person at risk for the development of lactic acidosis. And lactic acidosis is very fatal. A third of people will die to get it. So that's why it's so highly respected. Liver disease puts the person at lactic acidosis. Alcohol abuse. And this drug, when this drug first came out, I had a person had those weekend bingers. You know, the guys that don't drink through the week and then they go get a case and they drink it over the weekend. It's like, well, what do I do with that? So I called the company and they go, we don't have any data, we can't tell you. So here's what I do with that. If I have somebody who admits to regular alcohol intake, 2 to 3 beers a night, 6-pack, at night, I just avoid it. I move on because I don't know. Patients rarely tell you exactly what they're drinking. So since I have other drugs, I move on to something else, which is unfortunate because it's really a good drug. But I just avoid it, especially in bingers. They worry me the most. Chronic alcohol intake, the liver kind of adjusts to that. But when you do these huge binges, those always make me more. So that's my personal. So regular, moderate to heavy use, they don't quantify that. So I can't tell you if they do such and such, then avoid it or go to another drug. Pregnancy and lactation, it's not recommended. It's not teratogenic. It just does not have the power to control blood sugar during pregnancy. So if a woman gets pregnant while she's on metformin, no worries. But you will probably have to move her on to insulin because that's the drug of choice for gestational or for women who become pregnant that have diabetes. Okay, so that's the first thing to consider. Who do I not use it in? So if those aren't present, then you can start them on the drug. So the drug comes as a 500, a 850, and a 1 gram extended release. It does come extended release 500, 750, 1 gram, sorry. Here's what I do. The recommendation is, I think, to start them at 500 twice a day. I never start them that high. Here's the reason why. It is such a valuable drug, you want to be able to use it to any dose that you can. If you start too high, they will have GI upset. It's a guarantee. And they'll develop diarrhea. So a side effect that limits the ability to use this drug is diarrhea. And in just diarrhea, it is like I can't control the diarrhea. So it becomes really difficult to use them in those folks. So I always start with one 500 milligram tablet a day. This is my own way, and a lot of people do it this way as well. I start with one in the morning, and I have them take it at the end of the meal. So, and that will slow down the absorption. That will usually keep them from having any upset stomach. I'll have them do that for 1 week. If after a week they've had no diarrhea or whatever they've had is tolerable and they have no GI upset, then I instruct them to go up to twice a day. Or to 2 500. So I usually will have them do a 500 in the morning, 500 in the evening. And I'll leave them there until I see them back. Usually I see people fairly quickly back, maybe in 4 to 6 weeks. And then if they're still doing well and they still need additional drug, then I'll go up. I always keep it at twice a day. If I have trouble with adherence at night, then I will go to extended release in the morning. And I've given 2 grams extended release first thing in the morning and done well. Patients have tolerated it well. Here are some times when I modify that. If the people are always waking up with high sugars in the morning, but throughout the day they seem to do better, go down, then sometimes I will put that metformin in the evening. Because it will, what does that drug do? What's its mechanism of action? We kind of alluded to it. Its target organ is what?
Liver?
Liver. So it suppresses glucose output whenever you give it. Glucose output overnight is high in people with type 2 diabetes. Everybody has to have glucose throughout the night, so the liver is really good about feeding you, but in people with type 2, it's elevated. So their blood sugars in the morning can be high. So sometimes I'll use that metformin late in the evening with supper or maybe at bedtime with a snack to try to get their blood sugars more normalized in the morning. Fasting blood sugars are like the set point. If you start well, you can usually maintain it. If you start high, it's harder to get it down. So that fasting blood sugar will be a big goal for us in getting it in range. Questions? Okay. All right. So what can you expect? Every drug I talk about, you need to know the clinical effect. I use this information when I'm looking at somebody and I'm thinking about where are you and where do you need to go in terms of glycemic control. So I always want to know what can I expect from an A1C lowering and what can I expect from a blood sugar lowering if that information is available. Metformin's pretty powerful. It can lower blood sugar, A1C by 1 to 2%. That and the sulfonylureas, no oral agent beats them. Okay? They're very powerful. They'll lower fasting about 50. Is it fasting or glucose? Fasting, 55 milligrams per deciliter. That's big. Okay? Now, so it's one of your powerhouses. The other is no hypoglycemia. If a drug does not directly affect how much insulin you produce, then usually there's no hypoglycemia. Okay? And it's weight neutral. It doesn't increase insulin production, so it doesn't produce weight. Okay? So it's easy. Start looking at the mechanism of action of the drug. You can already predict what's it going to do to weight, what's it going to do to on low blood sugar episodes. Side effects. So now what can I expect that a person might complain about? GI is the most common. The gut will adapt. That's why if you will start low and advance it as the person can tolerate it, within about 3 months, the gut will adapt. It's a very adaptive organ, but it rebels if you change things quickly. So if you go on vacation and you eat really differently than you eat at home, does your gut not bother you? Yeah, you're too young. As you get older, your gut will bother you. Okay? So be patient with the drug. Here's another thing. If I advance the dose of the metformin, let's say at 1,000 milligrams, they are doing well and having no problems. I go up to 1,500 and they're coming back and going, I can't do that. It hurts my stomach. I've got diarrhea. I can't do this. Back them down to the last dose that worked and keep them there. Sometimes I will try to advance it again. I might go with 250 advancement instead of 500. And I'll push it till I get to the highest that they can tolerate. But I'll tell you, I rarely go above 1,500 to 2,000. Remember dose response curves? You know all that stuff I taught you in the beginning? It really did matter. Dose response curve. Okay? Usually at that 50 point, you've got about 80% of the effect of the drug. Same with metformin. When you hit about 1,750, you are 80% there. Well, if you take it on up to 250 to 2,500, you're not going to get the same incremental increase or impact on blood sugar. So that's why I usually, if I have not gotten to where I need to be with that patient at 1,500 or so, or 1,750, I'm usually adding another drug at that point. You don't have to. You can go on up to 2,000, but I'll tell you, I rarely go above 2,000. When would I do that? Finances are a problem. Patient doesn't want to take more drug. They're dragging their heels. So there may be times, or I'm buying time for them to get used to the fact that we're going to have to add another drug or add insulin. So GI symptoms, early satiety or anorexia, that can be a good thing. Nausea with or without vomiting. I would say it's more cramping. It's more that cramping you get with diarrhea is what they'll more. Or my stomach really bothers me. Check to see if they're taking it on with food. Often they're taking it without, on an empty stomach. That will increase that those side effects. They will go away. They will adapt, but it takes a while. So sometimes they don't last that long. Did I put vitamin B in yours? I changed y'all's, but I didn't roll it back off. Okay, so the other thing is long-term use with metformin will decrease vitamin B levels. So if you've had people who are at risk, you've got an older patient that's on it, or they've been on it for a long period of time, check vitamin B levels periodically and replace if you need to. Because metformin can cause lactic acidosis in situations, especially in hospitalized patients, when you're interfering with the kidneys, you may want to, a lot of hospitals will have protocols to withhold metformin during certain procedures, if they're going to have x-rays with IV contrast. JC, you all have one in your hospital, you know?
Do what, I'm sorry?
A metformin protocol, when do you withhold
Yes,
this?
we withhold it, I think it, 24 or 48 hours. I think it was 48 hours post and then 24 prior.
Okay. How do you communicate that to providers?
Not very well.
Oh, okay.
It was actually really, I was kind of amazed when I worked there because we had the protocol written and the only time it was really enforced was in the ER. But for our patients that were just, that lived there, that were from like someone in the city,
Yeah,
they didn't do
really.
it.
What about, even in radiology, they didn't do that?
Like we had to tell them, but it wasn't directly from their doctor.
Huh, okay. So things like acute renal failure, you know that radio contrast dye can cause a renal tubular acidosis. So usually withholding it until renal function comes back to normal or baseline is usually what's recommended. So during surgeries, after a major trauma, severe infections, and acute MI, all of those are times where lactic acidosis can occur, but also decreases in renal function. How does this drug work? Well, it has lots of different mechanisms. It works on the liver to decrease hepatic glucose output. It prevents the breakdown of glycogen. It also works in the periphery to decrease insulin resistance. That's why it's so effective. So really good drug. I can tell this is the end of the day. It's a really good drug, so use it. Eat a bite of vegetable. How quickly can you titrate? You can titrate it every week if you want. I usually get, as long as I can get up to that 1,000 milligrams, I will sit there for a while. Especially it depends on where the person is. If they're newly diagnosed, then I may go slower. Here's the reason why. Anytime people get a diagnosis of diabetes or they are placed on a drug for diabetes, they get more serious. Okay? I can't tell you how many times I've been burned by patients where I did not figure out exactly what they were eating. And a lady who was in probably her early 70s, she was fairly normal size, probably a little bit overweight by weight, but looked fairly normal size. It was at a time where we didn't have all these drugs, and we were putting her on bedtime insulin to try and get her morning sugars down. So I put her on a dose that I use in almost everybody. Next morning, I get a call from her family saying they had to transport her by ambulance to the hospital because she had too low blood sugar. So when I got her in the next few days, I said, okay, tell me what happened, because the dose that I used should not have done this. Well, what she didn't tell me is that she drank a lot of Kool-Aid. I didn't figure that out. And so she stopped it. And so all that sugar load gone and then we put insulin on top of that. So I find people do that a lot. They don't tell you about the bad stuff they're doing, or I shouldn't say that. I don't like to call food bad. They don't tell you about things that are having a great impact on their blood sugar. Then you make a decision, and lo and behold, they get in trouble. So now what I usually tell people when I start them on insulin is I tell them, don't change your diet at all. Don't do anything different. And then as we see how you do, then we'll start making modifications. But if they make big changes like that, they can get into serious trouble. So if you are going to, if you cannot get them down, you should know within a month or two if the metformin is going to work and hold it. You can hold it longer. I mean, you can continue it longer. I tend to early on with people give them longer periods of time so they can adjust to changes in diet, changes in activity. Just coming to grips with the concept is that I have this disease or this condition. Now, if I'm adding it to people who have had diabetes a long period of time, I might be more aggressive and keep moving things up. Because usually you'll hit a stalemate at about 6 months. They're like, oh, I thought this would go away, or oh, this is lifetime. So they start to come to that grips with things have to change and I have to change them for long periods of time. It isn't just something I do now and then I can go back to what I was doing. So sometime around that 6 month mark, they hit that realization is that this is forever. Did that happen to you?
No, right away I kind of sunk in that it's forever.
Sometimes I'll have parents with young type 1s come in and after a few months are like, I want this to go away. This is it. I'm done with this. No more. And you're like, okay, but...
Yeah, my parents definitely took it hard. Maybe even a little harder than I did. But yeah, it sank in pretty fast.
Okay, that's healthy. You did well. A lot of patients, that all that change, all that energy, they start wearing out with it. So you really have to keep with them and helping them modify and coming to the point where they can make the changes they can live with, and the ones they can't, you accept and you address later on. So you have to be lots of mercy. But when you've got a child that's got type 1, it's a different situation because it's an emergency. Here we've got a type 2 that we're talking about with adults. Questions about that? Do you feel comfortable in metformin, when to use it, when to prescribe it, what to expect out of it? So you would, on average, check their blood sugar in about 3 months. Not their blood sugar, but their A1C. Now, I'm going to tell you what I do, but don't let this change what I've told you is the standard. So if I have people who have, let's say they come in and they've got A1Cs in the 10, 12, 14% range. Let's say they come in and they work really hard. They've made big changes, weight's got stabilized, or they even lost weight because they tried to. They're taking their medicine, they're doing everything right. At about 6 weeks, I'll redo it because I know their A1C will be lower. Because the last 30 days of your blood sugar has the greatest impact on your A1C. So I'll do it to encourage them, to say, look how this has paid off for you. But it's not standard and it's not stable. So you have to, I use it for that, in that regard, but it isn't necessarily what you're supposed to do. Okay, let's go, we can do one more drug and get that knocked out. We'll stop after the sulfonylureas and the meglitinides. So the sulfonylureas and the meglitinides have been around, well, the sulfonylureas have been around a long time, probably since the 50s or 60s. Okay, so they're coming into 60 to 70 years they've been around. These drugs, if you look at the next page, they stimulate the pancreas to produce more insulin. They work on channels. Look at that picture. They're actually called SU channels, and they cause a conformation change in those channels that allows potassium to come in, and eventually that allows more insulin to be released. The meglitinides also work on that receptor, but they work on a different part of that receptor. And they don't sit on the receptor as long as the sulfonylureas. So the sulfonylureas are pretty potent. If you look at under clinical effects, they also can drop A1C about 1 to 2%. So if you put metformin and a sulfonylurea together, that is the most powerful combination you can do from an oral agent. You can get a 2 to 3% drop in A1C. Drops fasting about, I think, 60, what am I thinking of? 60 to 70. The downside is I told you what happens if you increase or change the amount of insulin that is released. What are the two things that are going to happen? They now have more insulin present, so what can happen? Weight gain, and they can get low blood sugar. You have now taken the ability to control blood sugar, you've removed some of that control from the body. So blood sugars can go too low. Why do they gain weight? I'm trying to treat diabetes and I'm causing weight gain. Why does that happen? Why were they losing weight, or why could they eat more and not gain weight? Why was that? Say it again.
That wasn't storing the sugar?
Part of it. That's part of it. Now they have insulin around, so they usually can maintain that fat to the most part. Where is that excess sugar going? If their sugars are high, let's say they're in the 300s, where's the sugar going? They're peeing it out. Okay? So you can eat and you just pee out your sugar. Does that not sound like a great diet plan? Wait till we get the SGLT2s. We actually induce that. So they are eating and wasting calories. Okay? Just in watching patients over time, I think that they eat about 30 to 40% more than what they need. But they pee it out. So when you then give them a drug like sulfonylureas and their insulin levels come up, what's going to happen to the amount of sugar they then pee out? It goes down. So guess what? Their weight goes up. Okay? So this happens when we put them on insulin as well. So that's one of the reasons we weigh them. I look for them to gain weight. It tells me that I'm pharmacologically doing what I wanted to do. Then I'll work with getting their calories more in line. But that's why their weight goes up. So if you want, because they hang on to more of the energy that they take in through their diet. So then I'll work with them to get their calories down. It's hard. They get used to eating that extra food. It's hard to get them to go back. Okay. What about the meglitinides? I really like this class of drug, and I'll tell you why. So it sits on the sulfonylurea, the SU receptor, but it doesn't sit there very long. When you put something like glipizide or glyburide in a person, it gets on that receptor and it just sits. It parks. So people are getting increased insulin boosts all throughout the day, but they're also at increased risk for low blood sugars throughout the day. So I like the meglitinides because they get out on that receptor, they do their job, and then they get off. So they may only sit there for 2 or 3 hours. So here's where they're good. Sulfonylureas, if you don't eat consistently, then you put yourself at risk for a low blood sugar. But if I give you a meglitinide and you eat breakfast, because we're going to have you take it with food, then it's gone by the time you decide to skip lunch. So the risk of low blood sugar is much lower with the meglitinide. So I like it for those inconsistent eaters. Older people. Here's a guy that I saw for a while. He had a backhoe service. So he never knew where he was going to be in the day. He said, I get my calls in the morning, I load up my backhoe, and I go do the job. And I may be done by lunch, but usually I'm not, so I may be in Godibo and I go to the diner, or I, never know where I'm gonna grab food, never know when I'm gonna eat food. It just made me nervous all the time, and he's operating a backhoe! So this was before we had a lot of different drugs we could use. So when the meglitinides came along, it's like, yes! So then he just had to take it when he ate. God, I felt so much better. For him, or anybody in the way of the backhoe. Okay? So, unpredictable meal plans, skip meals. You find this a lot in older patients. They don't work anymore, they don't have to keep to a schedule, so they may just kind of eat whenever. These are good drugs. The other thing that's good about them, if you look down at this chart, if you go across, repaglinide's my favorite in this, and if you go across, how's it eliminated? Biliary, no kidneys, so that's good. So if they have reduced renal function, I'm not going to put them at higher risk for low blood sugar. Okay. Meglitinide I look at as a weak sister, but I do use it every once in a while when I just need a little bit of drug effect. Got an older patient, 80 years old, can't control their blood sugar, but I can just hit them just a little bit, and I can get their blood sugars down and keep them out of symptomatic. The other three, glyburide, glipizide, glimepiride, they're great drugs. They're much longer activity. Patients can take them once a day, but they're at greater risk for lows. Look over there to the side under metabolite administration. Some of them have active metabolites, some of them don't. So why would I worry about glyburide? If it's got an active metabolite, where did that get created? Liver, okay? So remember, most drugs metabolize in the liver to a metabolite that's in water soluble, the kidneys can get rid of. So the liver's done its job, I made you a metabolite, sorry it's got activity, now the kidneys are going, but we can't handle it. So what happens? They're at risk for what? Low blood sugars. So glyburide in older people, probably not a good idea, especially in renal insufficiency, because you've got those weakly active metabolites. On the other hand, glipizide, metabolites inactive. So if you have renal insufficiency, you're going to use the sulfonylurea, then that's the one to go to. The only problem with meglitinides is you have to dose them with every meal. So sometimes if they're eating 3 meals a day, I find that gets hard to get them to take it with every meal. So those are the good and bad about that class. Some people don't like to use the sulfonylureas. They feel like there's been data that shows that maybe they burn out the beta cell faster. I don't know, maybe that's true. Most of the time, by the time I get people, their beta cells are fairly well gone. But I can still get some use out of a sulfonylurea. So I like the class of drugs. It performs well. You can't get a person on insulin or a GLP-1 agonist. They're effective. That's my opinion. Side effects, they're fairly well tolerated. Their big side effect is low blood sugar. So you got to consider the person. Are they a fall risk? Don't put them on that. Will they monitor their blood sugar? Nope, not at all. Well, I might not go that way then, because they won't monitor. Dermatologic is a fairly low risk, but it can occur. They can get rashes, they can get photosensitivities. It has a sulfa structure, so if you have a serious reaction to sulfonamides, you might want to think of different drugs. In my whole years of dealing, 30 years of using sulfonylureas, I've seen that happen twice. But I do pay attention. I've got somebody who's got has had a severe reaction to a sulfa-containing antibiotic. GI, most people tolerate it well. They're taking it usually with a meal, so usually isn't as much of a problem. Well, this was a fun day. Y'all did really well. Thank you for hanging in there.